Hello, welcome to Doc Talk Live. I'm with Ken Bramlett. Ken, good to have you.
Yeah, man.
Appreciate you letting me corral you today. I know you've had a busy day, probably doing knee replacement. I don't know what was on the books today.
8 knees, 1 hip, and 2 shoulders.
Wow. So I appreciate you taking the time. You're busy.
No problem.
Busy guy doing a lot of joint replacement, and we're going to talk today a little bit about knee replacement. I want to sort of skip over conservative treatment.
Yep. I got it.
So we can get right to the bones of the matter, if you will. So a patient has had severe arthritis in their knee. They've exhausted therapy. They've exhausted injections, and they're ready to walk again. They're ready to play again. That's where you might come in with surgery, and now the patient is trying to figure out joint replacement. In sort of take me through, maybe in a nutshell, the last 15 years of joint replacement in terms of invasiveness, recovery, products. What should our viewers pay attention to?
Well, it's a big subject, but to narrow it down, I gave a presentation last night, so it's kind of fresh in my mind. Here's the deal. Knee replacements have gone in the mid-60s to a kind of a tractor version, if you will, very heavy duty, cut a lot of bone out. It was pretty invasive. The exposure was 12 to 14 inches long. It was
so big incision.
Big incision. It was a week to 2 weeks in the hospital. In fact, when I was at training at Harvard Mass General, which is the world's mecca, when I was in training there, we kept people in the hospital for joint replacements, or they did. I was just part of the deal, watching it. But for 2 to 4 weeks, it was not unusual.
So it's a long recovery.
Very long recovery. Expected to go to an extended rehab facility. Expected to go to therapy thereafter.
So how have we shortened all this?
Well, we've shortened it a lot. In fact, having gone to 3 different major institutions in the late 80s and early 90s, one in Munich, Germany, and one in University of Colorado, and then in Mass General, I actually went around and did several fellowships and traveled around to see who had what, and kind of looking around.
So what'd you learn? What'd you find out?
Everybody did everything different.
Okay.
That was the most important part.
All right.
So you really need to learn to find out what you didn't want to do or didn't have to do to get a good result. So we started a process. The most important thing, that patients are very poorly educated.
Sure.
They're almost clueless.
But they're getting more and more educated. They're watching
now.
Shows like this, perhaps.
They were poorly educated, so we started a process actually called prehabilitation. And we were strangely enough, no one had ever done that before. So it's like training for a 10K race.
You want to get them ready before their surgery.
So we started that. We went from a hospital stays that were our norm, and even this region here in the South, at that time was 14 to 16 days, and we reduced that to a 2-day stay within a year. That was
back in
91,
okay.
1990.
All right.
Actually, 1990, 1991. And so we put a protocol in place, and kind of what we refer to as our Ortho Health Solution, and we've been doing it ever since.
Okay.
So in actually 91, we did even outpatient total hips and total knees.
How about structurally with just the surgical technique itself?
It's changed drastically. We minimized the process and went to what we refer to as minimal invasive surgery, where the incision is, 4 inches, 5 inches long.
Okay, now that's what I want to get at.
Yeah.
How do you do that? How does that work?
Well, it's on a large patient, it's like acreage. The bigger the acreage, the bigger the fence. So you have to make a large incision on a heavy person. If you get we had a 280-pound person a day, which I don't prefer to do sometimes, but you have to go to a 6 or 8 inch incision for a hip or a knee of that size. But for a normal person who's the 170 to 200-pound person, you can get away most of the time with somewhere between a 4 to 7 inch incision. But the key is how you handle the soft tissue. Totally is a soft tissue procedure, really.
Okay.
Cutting bones is like, color by number, coloring book. You cut the bone, you cut the bone, you cut the bone. The soft tissue, which is the envelope around the knee, and the ligaments thereafter on the medial lateral side and posteriorly, are what holds the knee structurally in place, what allows it to have motion. So everybody knows what an ACL is. Well, the ACL is done because it gives stability to the knee. So everybody gets support injury in their 15, 18, whatever. they go get it done. So you have to have the ligaments. It's often overlooked, the ligament aspect of a total knee. Even you have the common the conversation these days, or people are concerned about, do I have it done, minimally invasive, do you cement it, do you do cementless? Everyone's different. So you have to, quote, custom each patient's condition into what each implant use is going to be applied to. There's a large number of implants that have been made over the years, over 100 types, but they all come down to one thing. They cover the femur, the distal end of it. They cover the tibia, which could cut it back. You cut out only about 3 to 4 millimeters of each one. The most fascinating thing of all this, for the information of this conversation, people still today think you're taking 6 inches of bone off the distal femur and 3 to 4 inches off the tibia and putting this big, long, almost mechanical.
You're not doing that.
You're taking off 4 to 6 millimeters of bone, skimming off the femur, skimming off the tibia, and replacing it with just a kind of almost a shell of the end and a shell on the top of the tibia. So you're taking away approximately 12 to 15 millimeters of space and interfacing that with the implant.
Best case scenario, how long is the patient in the hospital for a total knee replacement?
Best case scenario, the best case safest scenario, 12 to 24 hours.
Okay, and then best case scenario, how long before they resume all their normal activities, that they're good to go?
That's the
best case scenario.
Okay, that's the kind of the golden question about this. If the patient is prehabilitated, which we found this to be true, we can push that to almost a 2 standard deviation variation. If the patient is prehabilitated and is clear, what we saw also, I've seen for years, I've done like 15,000 total joints. Okay,
15,000 joint replacements.
Okay. The most important thing is if they are clear and understand the plan and not much deviation, a clear stepwise path. Okay, and if they've kind of done some preparation and if they understand their responsibility to the process, they can be up today. Everybody I did today will be up today. I'm fixing to go see them. Okay, one of them's already gone home. But
I have a friend who's a surgeon.
Yeah.
Okay, he needs both his knees replaced.
Right.
Does not want to miss any work, and so he's just gonna wait until he dies in order to get his knees replaced.
Bad choice.
Okay. Or until he can't work anymore.
All right,
and so my question is best case scenario,
Yep.
he needs both knees replaced.
2 weeks.
He would be off work 2 weeks and back to work in 2 weeks.
I have a PA who's worked for me for 26 years. Okay, and we've done together, he and I together, over 25,000 cases. Okay.
Okay.
He's 76 years old. He's been working with me since he was 50.
Okay.
Okay. That tells you that's a sad story about me. But the case is that I did his knees 3 weeks ago on a Wednesday. He went home within a day, both of them, same time.
So you have both bilateral total knee replacements.
One of them was done.
Went home within 24 hours.
Went home within 24 hours. Well, he was going to go the first day, but I didn't want to let him go.
Okay.
Because he had some hyponatremia, so we had to hang around to have
his sodium was low. Okay.
Right. He went home within a day. I think it was 2 days because the internist kept badgering him about his sodium. But he was walking around, moving around. He was ready to go home, but they kept saying, no. Okay, but the point is this. Day 12, he came back to work.
Okay, so he was back to work within 2 weeks. Is that because you needed him, or is that because
No, he didn't want to because he could. Well, I needed him for sure, but he wanted to come back because he didn't want to sit around. If you want to go to work, you can go to work.
All right, you got some cool images to show us?
I've got an example of a knee replacement just to show you the sequence of how it works. The soft tissue is the most vital aspect of this.
Well, then show us that part. And what I'll do is I'll turn this around, see if I can work this thing, okay? Okay, so I'm in Dr. Bramlett's area here where he takes a break, and I'm not the best cameraman in the world, so let me see if I can find it. There it is, right there. And go ahead, Kenny, talk to us.
So here we go. So the latest technology in the world today is a knee that's 3D printed. So this is a surgery of a 3D printed knee that is made directly off a CAT scan, which reproduces the exact mechanical image, the exact mechanical alignment of a patient's knee. From the femur to the foot is a neutral mechanical axis which would be reproduced. So this is a surgery showing where the soft tissue exposure is taking a knee. This is from looking down on it, okay, from the top. This is looking at it from my side. This is my surgeon view here. And this soft tissue, as you see cutting out here, pretty heavy for most people, so pardon me if you're having trouble with this. This is the layer of inflammation, arthritis in the knee. This is the fibrotic synovium.
People are going to see this and they're going to say, no way am I leaving the hospital in a day.
But they do.
This looks pretty gruesome.
They walk within 2 hours.
Walk within 2 hours.
Very commonly. That's our standard protocol.
Incredible.
Okay? And so that whole process is taking the knee and exposing and cleaning this tissue around the kneecap, which is most likely, for most people who have complications, is attracting the kneecap. So this is a synovium in arthritic tissue. Arthritis is a synovial tissue problem. It's not difficult to get the alignment. It's difficult to manage the soft tissue. That's where the money is in doing a total knee replacement. So the idea about robots and all the other things, it's a marketing process.
Say that louder.
The robot is certainly, it's a marketing process. It does not, this is cutting the kneecap.
Oh man.
Which a robot doesn't do.
Come on, Kenny.
I mean,
that looks like big time surgery to me.
It's big time surgery, but it's standardized and consistent, and it's actually very safe.
All right.
I mean, it's a matter of how you do it.
You did how many? 15,000 did you say?
I've done 15,000 total joints. We've done about 11,000 knees.
Why is it that some people will go to New York or Chicago? Is there something special going on there, or is it just marketing?
I'm not going to say one thing or the other about that, but there's a lot of marketing to be involved with it. There is that. There's no question about it. And if you think that you're going to be able to go out of the hospital on the same day, that's appealing to people. We've been doing that for actually about 20 years.
Okay.
When we developed rehabilitation, that made people capable of being much more aggressive with themselves. I mean, I've had people fly a plane within a week.
Okay.
I mean, everyone's a little bit different, but standardizing the process of how you manage the soft tissues, specifically how do you get them ready, and it takes sometimes people 2 months, some people 6 months.
I'm gonna let you pause that just because the volume is tough. Well, I'm gonna stop it there.
That's fine.
Okay, Kenny, and how do people find you? How do people get to your website? Because I bet you've got a lot of good information.
Well, I certainly have my name as an orthopedic surgeon, Bramlett Orthopedic, which is just use an easy reference. But kbramlettmd@gmail is another way.
Oh, good. That's your email address.
Yeah.
Awesome. Well, if people have questions about minimally invasive joint replacement, which
Outpatient surgery.
Outpatient surgery, that looks pretty invasive to me.
It looks that way if you've never seen it before, but in our routine, that's totally normal. And again, it's about the soft tissue around the knee, aligning it, and also, just how you manage the soft tissue and how the immediacy that they can get control of their muscle. That's a critical key.
Kenny, I appreciate you you doing this. Let's do shoulder or hip next, okay?
Anytime you want.
Awesome.
Okay. Good day.